It is already recorded. I'm just trying to do a shorter little snippet for this so that during spring break, if you want to start reviewing your EKGs and you want to say, hey, I want to review calculating segments and intervals, boom, here's a short video out of the monstrosity. You can just beeline right to it. On your EKG exam, it will be your responsibility to understand the different waves, intervals, and segments. My job is to explain to you right now what those things mean. We recognize that the picture up on the screen where you see the P wave, QRS, and T, that is the typical perspective from lead 2. Remember, we talked about this last week, Tuesday, right? That picture would definitely change if lead 2 was strapped on backwards. We learned that on Tuesday. So now I'm going to tell you what all of those waves represent. And I did this on Tuesday already. The P wave represents atrial depolarization. What will happen as a result of that electrical event? What mechanical event will happen? The atria will contract. Okay. Over spring break, you're going to watch a lecture called The Cardiac Cycle. And you will realize that when the atria contract, they actually push a very small amount of blood into the ventricles. The ventricles fill, mostly 80% of them fill passively, just from blood returning back to the atria. The AV valves open like a trap door, and the ventricles fill 80% when the heart is at rest. When the atria contract as a result of the P wave, it's only that last 20% of blood that's squished into the ventricles. I am going to tell you how we can measure the time that the P wave lasts. Here's how you're going to do it. In your lab manual, there's a table in your EKG section where you're supposed to calculate the length and time for these different waves, complexes, intervals, and segments. If you have a ruler and you're measuring for the P wave, you would measure in millimeters the distance of the P wave from where it begins to where it ends. Then you would put that data into this equation, the velocity equation. Velocity equals change in distance over change in time. Velocity is the paper speed. We use 25 millimeters per second. On your EKG exam, to keep you all from cheating off of each other, to discourage cheating, I might give you a different paper speed, but I have to give you paper speed. Do not assume. Do not assume. It will be written on the exam. Okay? So velocity is your paper speed. Change in distance. Well, that's what you measure for these different intervals and segments. If you were measuring the time that the P wave lasted in your patient, you would measure the distance in millimeters from the beginning of the P wave to the end. That's your change in distance. Then you just solve for time. Where did you see this before? Could it be the first 20 pages of your lab unit 1 that you've already been tested on? Yes. You do not need to memorize the normal values for these times. You do not need to, except for one, and I'll point out the one we want you to be mindful of and remember. But all the others, normal values, are given to you in your lab manual in this table that I'm speaking of. You do not need to commit those to memory. What about the QRS complex? If you were measuring that, you would start from the Q, if it's there in your patient, If the Q wave, because we talked on Tuesday that some people don't have a Q wave, then you would mark at the beginning where the pen starts to go up for the R. And you would finish at the S. And again, you would plug that millimeters in length into the change in distance in the numerator. Your velocity is still your paper speed, and again, you would solve for time. The QRS complex is the electrical event that represents ventricular depolarization. What will happen as a result of that? The ventricles are going to contract. What does that mean? They're going to start to eject the blood. The ventricles start to contract first, as we talked on Tuesday, by pulling the apex up, and then the lateral walls contract, and that's when we get the actual ejection, stroke volume. A typical stroke volume is about 70 milliliters per beat. Then we have the T wave. Again, if I ask you to calculate the time that the T wave lasted, you would measure from the beginning of the T to the end of the T. You would plug that value into the change in distance. Velocity is still your paper speed. Solve for time. Are you okay, Justin? You're scowling, so I just want to make sure you're okay. Okay. The T wave is the electrical event for ventricular repolarization. What will happen as a result of that? We forget that relaxation is a mechanical event. In order to get relaxation, we must still have an electrical event called repolarization. So the ventricles will relax. At the end of the T wave, we now have the pen going back to baseline. Does that mean your patient is dead? It just means there's no electrical current moving and the heart is at diastasis. Remember, all 4 chambers are relaxed, and now we're getting blood returning to the atria and pouring straight down into the ventricles, and we're getting filling again. Excuse me. On Tuesday, I said to you all, the EKG pattern, it's not an action potential. And a lot of people in a clinical setting think it is. It's a comparison of vectors. And welcome to the club. Now you know what it looks like. Here is an action potential. We saw this in our specialized and contractile cell lecture. This is an action potential for contractile cells. 5 phases, numbered 0 through 4. Most of the heart tissue are contractile cells. So I'm now going to overlay this action potential and correlate it with the events you see on the EKG. When you see the R spike, that is when the contractile cells are in phase 0 and their sodium voltage gated channels are opening. If you really want to equate the EKG to an action potential, that's what we're doing now. The ST segments, all the segments I'm about to teach you, they are flat lines. They are when the pen goes back to baseline. The ST segment correlates with phase 2 of the contractile cell action potential. This is when we're getting calcium-activated calcium release. I talked about this on Tuesday. This is when, at this moment in time, the mechanical event that is happening, the cells would be contracting. We get peak contractile force during this phase 2, this plateau phase, which correlates with the ST segment. Isn't that misleading? We see a flat line. We think nothing is happening, when in actuality, if we could cut open our patient's sternum and look at their heart, their ventricles would be going, and that is when we would be getting stroke volume, ejection. Kind of cool, right? Yes, thank you. So when you look at the EKG, I encourage you, when you're looking at these flat lines, to not just think, oh, there's no current, but what mechanical event might be happening at this time that we are not seeing. It's a non-invasive technique that we're using. If we see the electrical events, we assume the mechanical events are happening. And in this case, contraction of the ventricles is happening at a time where electrically, we're not seeing anything happening electrically. Isn't that cool? I think that's kind of cool.
Is that because of like the latent?
Yes! There is still a latent period. We still need time to mobilize calcium. Of course, we learned from Tuesday we have two sources for calcium, and the extracellular source is not enough to generate this powerful contractile twitch. We still need the sarcoplasmic reticulum source. So there is still mobilization. There is still removal of the inhibition of troponin and tropomyosin. Absolutely. Good. Okay. Segments are flat lines. On your EKG exam, be ready to calculate the time for any of those waves or the QRS complex. Your job will be to know where you begin your measurement and where you finish it. Now on to segments. The segments I will ask you to calculate, potentially, depending on your exam version, the ST segment. Where do you begin? It's a flat line. So you begin after the S and before the pen starts to go up for the T. Segments are flat lines. You might get the test version where I ask you to calculate the TP segment. Where do you start that measurement? After the T, and you measure until the beginning of the next P. All right, why are those segments significant? The ST segment, as I just showed you, that is when the ventricles are contracting and we're getting stroke volume. What's the importance of the TP segment? That's when the heart is at rest. That is when it's getting its well-deserved rest, it's filling, and we're getting blood flowing through the coronary arteries. That is the only time when blood is perfusing the myocardium. Yes?
It's just between the T and the P.
Correct.
Segments.
Where else? The TP segment is between the T till the beginning of the next P. Segments are flat lines. Okay? There is also the PR segment. It's called the PR segment because not everyone has a Q. If someone doesn't have a Q, then this flat line would end into the part where the pen starts to go up for the R. So if I ask you to measure the PR segment, you measure from the end of the P to the beginning of the Q, if there is a Q. If there isn't, then you measure to the beginning where the R starts. But segments are flat lines. The PR segment is important because it represents the delay through the AV node. Just the delay through the AV node, which is one of two places where we see a delay, right? Okay. Now intervals, the word interval has the letter V. The word wave also has the letter V. And that helps me remember that intervals include at least a wave. They are not flat lines. For example, the PR interval, you would measure it from the beginning of the P until you get to the Q. If there is no Q, you would measure until that line transitions into the R. the importance of the PR interval is that it shows you the time required for atrial depolarization plus the AV nodal delay. This is the one we want you to know normal time for. A normal PR interval should not be more than 0.2 seconds. If it is more than 0.2 seconds, and another way of saying that is more than 200 milliseconds, it is suggestive of first-degree nodal block. And I will explain what the different degrees of nodal blocks mean. Just give me a moment. I'll get there eventually. Other intervals, QT interval. You measure that from the Q, if there is one, through the QRS complex to the end of the T. The QT interval represents the amount of time required for the ventricles to depolarize and repolarize. We are interested in the QT interval because if this lasts longer than it should, it invites the action potential to actually go into a circular serous route through the cardiocytes. And now you get this kind of reverberating action potential. We no longer have coordination, and the heart can go into fibrillation where everything is contracting at the same time and it's not if there's no coordination, then how do you get pressure changes? And blood will only flow from high pressure to low. Valves only open and close because of pressure changes. There will be a lecture that you sadly will have to watch eventually on cardiovascular pathology. And I do talk about long QT syndrome, LQT syndrome. Don't confuse that with a different acronym, okay? So LQT stands for long QT interval syndrome. And in the video, I talk about how my childhood friend, his child, at age 13, collapsed. His heart stopped. He was in cardiac arrest. He had an electrical conduction problem. And at age 13, he had to have a pacemaker put in. And it ruined all of the athletics that he could participate in. And at age 13, he was already 6 foot something. And he was being pursued by a lot of high school scouts. And it ruined him. What a thing to go through for such a young, gentle giant. But he's fine, and he's thriving, and he has adjusted. But LQT syndrome does get a lot of people. And you have probably seen this or heard of it on the news. The athlete, the soccer player, collapsing on the field, grabbing their chest and then face planting because their heart stopped and they had to be resuscitated. Children drowning when the parents say, I don't understand it. They know how to swim. How did they drown? And in the video, you will learn that for this LQT syndrome, many of them, they have genetic mutations in their voltage-gated channels. It can be in sodium or potassium. Those are the most well-studied. And if the person goes into a sympathetic moment, it can cause these voltage-gated channels to misfire and not close or open appropriately. And now their QT interval lasts much longer than it should, and it invites this circular current. And we don't get coordinated contraction. We don't get blood flow, and they faceplant. You've heard about the cheerleader cheering, right? And then keeling over. The football player and the coach is saying, but it wasn't hot that day, and they were well hydrated. It wasn't a dehydration. It's probably LQT syndrome. That's what gets them. They're on the pitch. They're competing. They're in front of an audience. Isn't that a sympathetic moment? How do you feel when you're in speech class and you have to get up and give a speech? The pounding chest, yes? Swimming. Well, how is that a sympathetic? They dive into the swimming pool or cold water. It's usually at the beginning of the swim season. The water is just a little bit chilly. You dive into that water and it's a little bit cooler than you think it is. Doesn't that take your breath away? Jumping into a pool that you know is going to be cold, you're like, mm. Some of them are found dead in their bed. Why? How is sleeping a sympathetic moment, Kara? Their alarm goes off. Their alarm goes off. How do you feel? I have an old alarm clock that is still on my side table. And whenever I hear commercials with that classic alarm sound, wah, 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 just watching the commercial, I'm like, so then these children don't get ready for school. The parents go in saying, come on, you're late, you need to get going. And they're dead in their bed. That just happened to actually a family friend of ours. Isn't that sad? Can you imagine going in and finding your grown child dead in their bed? It's awful. It's awful. So QT interval. From the Q, through the QRS, through the T, to the end of the T. TP segment, I already addressed that. That represents the time where your heart is at rest. P to P interval. Okay, from the beginning of a P to the beginning of the next P. What is that? What does that represent? A full cardiac cycle. We can go T to T, we can go Q to Q, we can go S to S, we can go R to R. And in fact, last week, I did have you calculate your R to R interval, didn't I? And I said that represented one cardiac cycle, one beat. Why did I use R to R? Why didn't I do P to P? Well, the R's are prominent. It's easy to see. That's why I chose R to R. And then the ST segment, as I said earlier, that represents when the ventricles are contracting and we're getting stroke volume. So tachycardia is an elevated resting heart rate. For our testing purposes, tachycardia represents a resting heart rate more than 100 beats per minute at rest. Bradycardia represents a reduced resting heart rate. For our testing purposes, that will be a resting heart rate of below 60 beats per minute. First degree block. I referred to this on an earlier slide. First degree block is a PR interval that lasts more than 0.2 seconds, more than 200 milliseconds. It represents that there is too much of a delay going through the AV node. It's taking too long. And again, if the delays take too long, it invites electrical action potentials to reverberate through the tissue, through those intercalated discs, and it can invite now that the heart is not beating in syncinction, in togetherness. Are there other kinds of AV nodal block? Is there a second degree? Is there a third degree? Yes, there are. Second degree, I don't want you to worry about it. Third degree, we start to see that we see P wave after P wave after P wave, and then we see a QRS-T. P wave, so atria and ventricles are dissociated. They're no longer communicating to each other. We're not getting the action potential traveling through the AV node, through the bundle of His, into the ventricles. The ventricle specialized fibers are reaching threshold totally on their own. They have their own pacemaker now. Remember, we talked about this. The further away you get from the SA node, the longer it takes to reach threshold. So the atria have their SA node firing, but nothing's getting to the ventricles, and they're on their own rhythm. That's third degree AV nodal block. So what would that look like?
Is that also called like afibrillation?
No, fibrillation is where we're getting a quivering, right up here. We're getting just a whole bunch of electrical activity, but there's no coordination at all. So for a third degree AV nodal block, we would get P wave, P wave, P wave, then a QRST, then P wave, after P wave, after P wave, okay? Now, I told you when I was teaching you your cardiac vectors on Tuesday, I showed you a vector showing you atrial repolarization. Remember, it was pointing up to the right. And I said, but this isn't one of the 5 you need to know, remember? But I also said, but I want you to see it because it's happening. It is happening. The atria are repolarizing. So I'd like to revisit that now. If that atrial repolarization was a vector I asked you to know, and it's pointing up to the right, and we recognize that lead 2 points down to the left, what would that look like in an EKG picture? How would our traditional EKG picture using lead 2, how would that change if we saw atrial repolarization? Here's atrial depolarization. What would it look like? Would it look like this? And then we would get our QRST? Isn't that what we would see? And students say, well, Kara, if you're telling me that atrial repolarization does in fact occur, and it does, it has to. Atria have to repolarize to relax. If you're telling me it happens, Kara, why don't we see it on the EKG? And this is where I told you, if you take an EKG class and you ask that question, this is they will give you. The answer they will give you is, the reason why we don't see atrial repolarization is because it's happening at the same time as the ventricles depolarizing, and the ventricles being so much bigger in muscle mass, their electrical event obscures the electrical event of atrial repolarization. It gets lost in the signal. Really? That's your answer. You gonna stick to it? Yeah, that's the answer. That's why. Oh, so what now, brown cow? If I have a patient at third degree AV nodal block, if I'm getting a P wave after P wave, and there is no QRST obscuring it, why don't I see it? So clearly that's not the complete answer, is it? And here's the other part of the answer. True, in a healthy person, the ventricular vent does obscure the atrial repolarization electrical event. The machine is only going to pick up on the bigger one. But the reason why we don't pick up on it with third degree AV nodal block is because when the atria repolarize, there is such a small amount of current over a longer period of time that the machine does not detect it. It does not detect that small amount of current over a longer period of time. That's the reason why. Okay? Okay. Fibrillation, again, a lot of electrical current. It's more of this circular current going all over the place, but there is no coordination, and muscles are getting their action potentials and then just contracting, and there is no movement, directional movement of blood. We need to stop that. We need to stop that. Okay. Almost done. On your EKG exam, on the multiple choice part, I will ask you to match your electrolytes to their descriptions. So on this slide, I have my hypers. On the next slide, I have hypos. Hypernatremia. What do we see? We see negative inotropy. Why? Why does having too much sodium in the extracellular fluid where sodium is found more abundantly anyway, why does that lead to a weak, flaccid heart? And the answer is the calcium voltage-gated channels that open during that plateau phase, sodium worms its way through. It competes. So now you're not getting as much calcium coming through those voltage-gated channels, and you're not getting as much calcium-activated calcium release. And the heart is getting weaker as a pump. Hypercalcemia, we see negative chronotropy, positive inotropy. That's what those signs mean. Why do we see, let's start with positive inotropy. Now I'm going to take, this answer is multifaceted. I'm just going to give you 1 point to remember for the test, just one. With hypercalcemia, the reason why we see an increased inotropy is because that should make sense to you. More calcium is coming through the calcium voltage-gated channels. We get more calcium-activated calcium release, and the heart is now having more removal of troponin and tropomyosin inhibition. We get a stronger contractile force. Okay, that makes sense. But why do we get a reduced heart rate? Why do we get a negative chronotropy? And here's the part where I'm just going to rattle it out, but when you come back from break, you're going to do a lab on it. If the heart contracts with a greater vigor, greater force of contraction, you get more blood ejected. And you have pressure receptors in the aortic arch and in the common carotid, right here, the carotid sinus, and those are called baroreceptors. They detect this increased pressure. If there's more blood, then those vessels have to stretch more, and those receptors detect that. When they detect more stretch, these receptors are modified nerve endings. And we know, because you're going to be tested on it tonight, that if a nerve is stimulated more, it fires more action potentials. That's how we code for intensity, don't we? So these baroreceptors, if they detect more stretch, they fire more action potentials up to the brain. And the medulla oblongata is the part of the brain that's collecting this data and going, yes, thank you for this information. We need to do something about it. And the resulting output command to adjust is to tell the heart to slow down in rate. So that is part of the reason why we see this negative chronotropy. Okay? Cool.
Would that be a positive feedback mechanism too?
It's not positive, it's actually negative. Mm-hmm. It is. It is a negative feedback. It's a reflex arc, absolutely. Thank you. And yes, and here, and your bag is back there. Yes, no problem. Now, what about hyperkalemia? Too much potassium in the extracellular compartment. Potassium is not supposed to be found in high abundance. Potassium is supposed to be roughly between 3 to 5 millimolar in the extracellular fluid. So if it goes up even 1 or 2 millimolar, that can be life-threatening. We don't mess around with hyperkalemia. Remember, emia means in the blood, an extracellular body fluid compartment. For the EKGs, all I want you to know is we would see tented T waves. Instead of sloped, they look very prominent, almost like they're an extra R. To quickly go through the hypos, hyponatremia, not getting enough sodium entering into these cardiocytes, we recognize they might have a problem reaching threshold then. That's one of our positive charges that we like to keep trapped in the cell or allowed to come into the cell, right? So this is going to lead to a decreased heart rate. Hypocalcemia, it's the reverse of hyper. We're going to have a weak, flaccid heart. We're not getting enough calcium coming in for calcium-activated calcium release. Then the heart isn't ejecting as much. Then the baroreceptors don't detect as much stretch. Those nerve endings then don't fire as frequently. And then the medulla oblongata says, all right, that's a problem too. And the resulting output to correct for that to the heart is, you better speed up. If you're gonna be a lazy son of a gun, then you better beat more often. Okay, so that explains the increased chronotropy.
So kind of in simple terms for hyponatremia, could you think of it as the heart is beating at an increased force, so it doesn't have to beat as fast?
For which one?
For the first one, natremia?
Hypernatremia?
Yes.
But I didn't say it has an increased force.
Oh, you didn't?
Nope.
What'd you say that for?
I didn't.
Hypercalcemia.
Hypercalcemia was an increased force. And then the heart was able to reduce rate.
Because of that.
Yeah, so if the brain could talk to you, it would say, hey, heart, you're doing so awesome. You've got such a good, you're doing so well. You're getting such a good stroke volume. Hey, you should take a longer break between beats.
Right.
That's for hypercalcemia, if you
Right.
want to think of it that way. Hypocalcemia, heart is weak as a pump, and now the brain is saying, you lazy son of a bitch. If you can't be bothered to give me 70 milliliters per stroke, then you better speed it up, buddy. Good? Okay. Then hypokalemia, it leads to a reduced chronotropy, and it also leads to a U wave. Now, a lot of times students think that a U wave is named because it looks like a U. No. Negative. A U wave is shown here, and it's called a U wave because that's the letter after T. So do you remember on Tuesday I showed you that there were 3 vectors for ventricular depolarization? And yet for ventricular repolarization, I was like, it happens so quickly that we have 1 vector that we have to worry about. Remember? Well, with hypokalemia, it can slow down this repolarization, and now we get separation of the ventricular walls from the IV septum, and we can see the T and a U wave. So that's the explanation why we see that extra wave. Okay? Okay. Can you please, real quickly, get out your EKG, find your TP segment, and calculate your TP segment in time.